For those who don't know me, my name's David Sando, and I'm part of the leadership group here at this prostate cancer support group. We are delighted, as always, to see people here interested in what we need to get over to you in terms of information and education. Now, there's no one better at getting information across to us than Gavin, Associated Professor Gavin Marx. He is a wonderful supporter of this group and the Prostate Cancer Foundation in general, and he's very well known in this area. And I have the pleasure of working with Gavin, who's the chairman of an AstraZeneca group called Empower, with other medical specialists like him, coming up with ways to communicate to doctors and to consumers on the things that we have as issues in our prostate cancer journey. So without any further ado, I'd like you to help me welcome Gavin to the podium, and he's going to talk to us tonight. Hang on, Nigel. About hormone refractory prostate cancer. And of course, he'll be talking about clinical trials as well. So over to you, Gavin, and thanks very much for coming.
Thank you very much for having me back here again. It's really a privilege to speak at this support group, which is a very dynamic support group and has really been instrumental in achieving some of the, together with the PCFA, in achieving some of the access to certain drugs that has happened over the last few years, and really been instrumental in giving our patients with prostate cancer a voice, which we've always seemed to be lagging behind other tumour groups, particularly breast cancer patients. But there's really been quite a dramatic difference over the last few years, and I think that's reflected in the treatment options that we now have for our patients with this illness. And really, hopefully what you'll see as well with the progress that's been made in a very short period of time, really in a 5-year, 6-year period of time. And really it's been quite dramatic, and it's been very exciting to be a part of that. I do apologise to some of the people who were here last year, because a lot of the slides are similar to that. 2010 was a very, very big year for hormone refractory prostate cancer, and you'll see that with some of the data that I present. 2011 has not been quite as positive, but it is very unrealistic to expect the sort of positive results that we saw in the 1 year. It's not really been seen in any other tumour group where there were so many great advances made in a very short period of time. So I think we have to be a bit realistic about what we can expect on an annual basis as far as incremental gains. But what it has done is given us the opportunity to be very much involved in clinical trials, and we've got a very active clinical trials unit here, as do many other centres around the state. And having people involved in those clinical trials has been instrumental in seeing the advances that we've seen. So really what I want to do tonight is focus on hormone refractory prostate cancer. And one of the big challenges is to actually define what we mean by hormone refractory prostate cancer. And that's been one of the issues, is that we're not always talking the same language. Not everyone's meaning the same thing. So I think that's been one of the challenges with trials to date. But now we have a better understanding about what we actually mean. And the names hormone refractory prostate cancer, or castrate resistant prostate cancer, or androgen independent prostate cancer, used relatively interchangeably, and we'll talk about that down the track. One of the things that has been very clear until recently is that it's been difficult to do clinical trials in patients with prostate cancer, and there have been a lot of reasons for that, and that's been one of the reasons why there were some lags and delays in getting people enthusiastic about doing research in this field. Probably one of the biggest factors was that we didn't have a good objective endpoint, how we could actually see whether a treatment was working or not. Now, in most other diseases that we treat, we can follow progress by looking at a lump in the liver or a lump in the lungs, which are quite easy to see changing objectively on scans. Prostate cancer tends not to involve organs very frequently, although it can do, but that's a much easier way to follow progress. What we see as a bigger problem in prostate cancer is the impact on bone. And bone scans are a little more difficult to interpret, because really what they show is a bit of blob of activity. So sometimes the bone scan can actually look hotter when things are under control. And so it's not been a very reliable way of being able to follow progress, although there have been some very clear endpoints that have now been defined, and that's made that easier. Probably one of the other challenges is PSA. Now, people can sometimes become addicted to the PSA because it goes up or it goes down, but it's a lot more complex than that. And you may find that some of your doctors don't rely completely on the PSA because it's one factor amongst others, and there are some problems in interpreting PSA. There's also been some problems in interpreting PSA between studies, and so that also made it difficult to compare results. But the PSA working group has now clearly defined those endpoints, and that's been very helpful. Probably the most important factor, and if there's one take-home message that people take home from this discussion, is that patients with prostate cancer are a very heterogeneous group of patients. And basically what that means is that there's a very wide spectrum of disease within prostate cancer. So it's not just prostate cancer as one disease, there's a whole spectrum. So there's some patients who've got very low volume, slowly growing disease where we don't need to do anything about it, and other patients who've got much more biologically active, serious disease where they need urgent treatment. They both still have prostate cancer, and that's one of the different difficulties in I think my phone's going off. That's one of the difficulties when you talking about a patient with prostate cancer, unless you have all the information at hand. Right? Oh, okay. If there's so it does make a big difference because there's quite a wide spectrum of disease, and that does influence the way we treat this. And also it makes it challenging to do clinical trials, because as you can imagine, if you've got patients in there who've got slowly growing low volume disease, their outcomes are going to be quite different to someone who's got a more aggressive biologically active disease. But now what's happening is we've got relevant treatments for those different patient groups. The other thing that we also need to bear in mind with treating our patients with prostate cancer is that it tends to be a disease of older patients, but not always. And the older you are, the more likely there are to be other comorbidities such as diabetes or heart or lung problems, which have implications for a competing risk, because patients can obviously run into trouble with those diseases before they run into trouble with their prostate cancer. And also it makes some difficulties in giving certain treatments which rely on kidney or liver or cardiac function to be safe. So the comorbidities become important. Really all the enthusiasm happened when there was a demonstration of a survival benefit with an agent called Taxotere in about 2004. And that was the first time we'd seen a positive result in patients with prostate cancer. And that really got everyone enthusiastic that we could actually make a difference with this disease with using chemotherapy or treatments other than hormonal manipulation. And then 2010 was the prostate cancer big year, and we'll talk about some of those results. And then I just wanted to finish off talking about some of the clinical trials that we've actually got open here. And again, they're not relevant for everyone, but they're relevant for certain disease groups, and we can talk about some of those. Oh. So just to put this in context, what we're talking about, this is the sort of disease continuum with people who are diagnosed with prostate cancer, and this is paralleled by what's happening with the PSA. Basically, people are diagnosed early in the piece, and that's usually with localized disease, and that can usually be treated by some of the local treatment options such as surgery or radiotherapy, and we won't go into the dilemmas and the difficulties in making those choices. After a significant proportion of those patients will be cured and the whole prostate cancer issue is over, aside from regular follow-up. But a proportion of those patients, depending on what the nature of the original disease is, will have a PSA failure where the disease comes back again. And usually we can manage those patients with hormonal manipulation. And depending on the nature and biology of the disease, some people can be managed with hormone manipulation for many years. Some people only managed with it for a short period of time. And the biology of the tumor dictates the impact that hormone manipulation will have. And so some people will have disease control for a long time and then never run into trouble with their prostate cancer again. There are some people who don't actually present with localized disease but present at this stage. But again, we can manage their disease with hormones for a period of time. And that's quite a wide spectrum as to what we can do there. What happens after a period of time with some of those patients is that the disease will flare up again. The PSA starts rising, and we know that there must be some tiny microscopic cells circulating in the bloodstream. Now, some of those patients may have what we call M0 disease, which means that we can't actually see that there are metastases or deposits in some of the important areas such as the bones, lungs or liver, but we know that there are tiny cells there. And so there's a bunch of treatment options that are now being considered for these patients. The next group of patients are those patients where the disease has actually moved to the bones, and that's where you can see actual deposits of tumor in those areas, and those patients have what we call M1 disease, or macroscopic or definitive metastatic disease, and there are a whole lot of treatment options that we consider there. Not everyone there needs to be on chemotherapy. Some people who've got low volume, slowly progressive disease can afford observation or other treatment options as well. Now, this issue of whether someone's castrate resistant or not generally is now defined as soon as the primary PSA failure occurs, patients are considered castrate resistant. Now, we used to previously call that hormone refractory, but they're not completely hormone refractory because, as you know, a lot of patients are still on their hormone treatments. So it just means that they're resistant to being castrate, where there's no testosterone being produced, but there is still some impact that the hormone manipulation will have because there are still some sensitive cells, but the bulk of the burden of disease is resistant to being castrate. So that's how that term castrate resistance has come about. And another way of looking at that is a term called androgen independent, which means that although there's still a need to keep LHRH agonists, the injections going, to dampen down any sensitive cells, they're actually predominantly independent to androgens. So that's when we need to start adding other treatments to that as well. And that terminology has been very confusing for doctors and patients, so don't be concerned if it's confused. But now we've got a better understanding of exactly what that actually means. So when we had localized disease, we talked about treating people locally. When the disease relapses, we talk about using various hormonal manipulations, and we can juggle hormone manipulations at different levels depending on the nature of the disease for different periods of time. And there's some people where we'd use hormones and try lots of different hormones, and other patients where we say, well, look, this is not driven a lot by hormones. Let's stop the hormones and use some other treatment options. And as I said, this docetaxel or 3-weekly Taxotere is the thing that really made the difference. I just want to highlight what a big problem prostate cancer is, and it's a big problem, and it affects 18,000 men each year. 3,000 men die with this disease, and it can affect younger men. So these stats are similar to the sorts of stats that we see with our patients with breast cancer, and it's only in the last few years that we're really starting to have the same voice as our breast cancer patients. And I don't want you to think that I'm neglecting Movember. I think it is an important thing, but it just takes me a bit longer. So mine will only probably come through in December, but I did start in Movember. So the other issue, I just want to spend a bit of time talking about TAX 327, which was the pivotal Taxotere study. What we had in the past, before Taxotere came about, was a treatment called mitoxantrone, which was considered the basic standard of care at that time. And what this was a clinical trial where the investigators randomized patients blindly to 3 different treatment arms. 1 3-weekly regimen of Taxotere, 1 weekly regimen of Taxotere, and mitoxantrone, the standard of care. And what we're really trying to see with this study was that, can we do better what is considered the standard of care? And what this study showed by these survival curves is the blue line of the people who are treated with Taxotere did better than the patients who are treated with mitoxantrone. And we can see by these curves that there is a survival benefit. And that survival benefit is very real and has a big impact on a number of patients. Now, what we talk about here is a median survival benefit. And what a median survival benefit means is the benefit for the whole group. Now, what happens with this is that some patients don't get a benefit from the treatment, and some patients get a very significant benefit from the treatment. So that's going to spread the median to make it a bit closer to the middle. So even though the median itself seems like a relatively low number, that's because that median is being dragged down by some people who are not getting a benefit. But clearly the people who do get a benefit get a much greater benefit than what the median shows. And what we need to try and do with some of our research is to try and pick out who are those patients that are going to get the long benefits and that should be treated with this treatment, and who are those patients who are not going to get a benefit, so we don't actually use this treatment at all, or stop using that treatment very quickly so they're not getting exposed to the side effects, and we can use something else that's more likely to be effective. And that's one of the things that we've got to be very careful of when we're interpreting medians, because they can sound relatively poor, but for individual patients it can be a very meaningful benefit. So what we saw with the Taxotere study is that it improved survival, patients lived longer, but when we're looking at this disease where we can't completely cure our patients, not only do we need to make them live longer, but we also need to make them live better. We need to look after their pain issues and their quality of life. And that was an important thing that also came from the study, was that not only did they live longer, but they also lived better. Their pain control was better and their quality of life was better. And PSA responses were also better. So there were 2 studies done at that time, and it's always reassuring when you've got another study that's done in parallel that shows the same results. And it showed that the survival was improved to close to 20 months. And it reduced the chance of someone dying from this disease by 24%. So this was a significant advantage. And as a result of this, it changed the standard of care. The important thing to say with Taxotere, though, is that it is tough treatment. It's not a walk in the park. It does come with some side effects, and we've got to be very clear that the benefits of treatment are justified compared to the toxicities and side effects that people experience with it. So it's not for everyone, and we need to weigh up the risks versus the benefits. So there's some people who've got very biologically active disease who would tend to respond much better to chemotherapy, and they're the patients who need chemotherapy more because they're getting more symptoms from their disease. So clearly those are the patients who would benefit from that treatment. But we also need to try and select the people most likely to tolerate the treatment, and also those patients who are most likely to benefit from them. We've got kind of crude measures at the moment, but there are some research studies going on at the moment to try and best identify those patients who've got disease that is going to best respond to this particular regimen. But the important thing that came from the Taxotere data is that suddenly people said, well, this is now the backbone, let's start adding to this. So we sent a bunch of animals out to try and develop some targeted therapies, and this is one of the things that has happened. One of the very important areas which, although hasn't been very positive in prostate cancer, is the issue of angiogenesis. Now, angiogenesis is a very important concept where tumours develop new blood vessels. And by developing new blood vessels, it allows the tumour to grow. The advantage of angiogenesis is that it doesn't happen in normal human function. The only times it does happen is during menstruation, pregnancy, embryogenesis, so in utero, or wound healing. So clearly this looked like it was going to be a very good target for prostate cancer, because obviously 3 out of those 4 things are never going to happen in men who have got prostate cancer. So we potentially have a target that, if we blocked, wasn't going to affect normal function. And so there was a lot of research done in angiogenesis. And the father of that was Judah Folkman, who appeared on the cover of Time magazine saying, I'm flattered, but it's mice, only mice. If you have cancer and you're a mouse, we can take good care of you. And that was because a lot of the research in the lab on mice showed a significant benefit with the addition of these anti-angiogenic agents. And so there's a lot of benefit that we needed to look for with using some of the anti-angiogenic agents. But the problem was that with some of these anti-angiogenic agents, we weren't quite clear that the targets were that essential. And that's where some of the problems are. Because what the process does is, if you've got a tumour cell there, it secretes a whole lot of proteins which make new blood vessels grow, and that allows the tumour to grow, but it also allows the tumour to send off some microscopic cells into the bloodstream, and that allows that to deposit elsewhere and set that whole process up. Now, what some of the new targeted agents were doing was blocking some of those proteins. But the problem was that it was quite a broad use of this agent, rather than specifically using a particularly targeting angiogenic agent for each particular tumour type. And so what was happening is, if we blocked one of these, another angiogenic protein would increase. So unfortunately, the angiogenic story was a little bit disappointing in prostate cancer. And so although it's been shown to have some activity in other tumour groups, although that in itself is now being questioned, the benefits are relatively small with this process. But it's still a very important concept, and I think it's still going to be a very important area of active research. But it comes back to the fundamental principle that targets are essential. So you can't just say we're going for angiogenesis. It's particular components of angiogenesis that we need to target. So what went wrong? I think we didn't have quite the right fit for that, but it doesn't mean that it's not going to ever work. It's an area of ongoing active research, but probably not quite where we are at the moment with this. But there were still 3 other very important things that came through in 2010. And this is an agent called cabazitaxel, which is really the new generation of Taxotere or taxane therapy, and it just worked slightly differently. And what was interesting was that it could trick cells that had already been exposed to Taxotere to respond to this new agent. And so this was a very important study that was done in patients who'd previously been treated with Taxotere. So one of the issues with clinical trials is we need to say, well, after someone's had Taxotere, what is the standard of care? And the standard of care around the world at the time was to go back to one of these older drugs called mitoxantrone, which still is considered an active agent in prostate cancer and still has its uses in some situations. And we did a randomized study where we compared cabazitaxel versus mitoxantrone. And these are in patients who'd previously been treated with Taxotere. And again, we see that it showed a survival benefit. So that was a very important study because it showed that now, not only after people have been treated with a cytotoxic treatment or with a chemotherapy, there is still scope to improve things by reusing another type of chemotherapy. And cabazitaxel, we'll talk about it when I discuss the clinical trials that are open, is now currently being actively researched around the world, and a number of centres in Australia are looking at cabazitaxel in a number of different settings. This is probably another important study, really just to put in a talk just so that we can tick the box and say that we've put it in the talk. And it does raise some important concepts, but it's never going to become available in Australia, and probably rightly so, because it needs a bit more fine-tuning. This is a treatment looking at Sipuleucel T, which is an immune-based therapy. And it's quite a complex way of delivering the treatment, where basically you collect some blood of patients, harvest their blood in a machine, and combine it with some proteins which stimulate the immune system, re-inject it to the patient, and do that course 3 times. And there was a study that was done, which there has been a little bit of controversy about the neatness of the study and the exact way the study was done. There were a few variables that don't quite fit with a very clean and reproducible study, but nevertheless, the study did show that there was a survival benefit. And as a result of this survival benefit, this agent became an important treatment in prostate cancer in the United States. The cost of this treatment is $93,000 for 4 doses of treatment, and the benefit with this is in the order of many weeks. And it comes with significant toxicity, and probably the problem with this comes back to actually understanding the target. I'm sure there will be a role for immune therapy in some situations, but there's certain biologies of disease that are more likely to be driven by immunity, where it would be useful to use these agents, but using it for the whole group probably doesn't justify the use of this agent. And certainly with that sort of very modest benefit and the difficulty in administering it and the significant cost, it's not likely to be something that's used in Australia. The other area where there's been a lot of enthusiasm is re-understanding the androgen receptor. So we know that prostate cancer is driven by androgens or testosterone, and that's based on the androgen receptor. And the androgen receptor receives testosterone from various places, usually from the testicles, which provides the bulk of the testosterone that's received, and some of it comes from the adrenals. And you'll see when we're manipulating hormones, we're trying to block different levels of those. But the androgen receptor becomes quite clever, and after a period of time, it actually shifts and mutates and works out ways to bypass the way that androgens stimulate that receptor. And the good thing is some of the scientists overseas are getting cleverer than the cancer cells and saying, well, let's see what those processes are that are causing that problem and developing drugs to block that. And there are a number of different ways that the androgen receptor can be influenced to block the way that the androgen receptor modifies itself to try and improve its survival, or to try and live longer and feed itself on more androgen. So there are different ways that it can do it, and it's probably not relevant to go through these, but just to let you know that using these different strategies, we can actually use other agents to try and block and change the way the androgen receptor responds, and by doing that, hopefully influence the outcomes of our patients. Probably the most important and advanced drug down that line is this agent called abiraterone. And what you can see is that prostate cancer cells get their testosterone from the testes and the adrenal gland, but importantly, there's a whole lot of action happening within the prostate cancer cells themselves. So within the prostate cancer cells, the cells are actually converting inactive testosterone into active testosterone, so it's making the active agent just where it needs it. And most of the drugs that we use block androgen on the outside of the cell. So the cell doesn't actually care what's happening on the outside because it's able to make its own testosterone on the inside. And that's where abiraterone acetate has become very important, in that it can actually block intracellular conversion of inactive testosterone to active testosterone. And again, another randomised trial was done, and we were very fortunate to be one of the international centres involved in the study, as were a number of centres around New South Wales. And really what this study showed, it was quite a dramatic study to be involved in, with really quite dramatic responses in some of our patients. And as a result of this study, which was a very positive study, this drug has received TGA approval and is currently in the process of becoming approved in Australia, which will hopefully be in the near future. It's hard to know exactly how long that'll be, but there are ways that this drug can be accessed in certain situations that are clinically relevant for certain type of tumours in a clinical trial process until we wait for this drug to become available. But again, this showed a survival benefit, a significant survival benefit, but the advantage of this was that it wasn't a chemotherapy. And so it's a very well-tolerated agent with very few side effects, the main ones being a slight drop in potassium levels and a bit of fluid retention, but certainly nothing like the toxicity that we've seen with some of our previous chemotherapies. So this looks like it's going to be an exciting agent. Where exactly it fits into managing the prostate cancer journey is still being studied, but certainly it looks like it's going to be an important agent. So 2010 was a very good year for prostate cancer, and we'll probably be flogging this slide for a few years now until we have a better year. But really, there were 3 positive studies where there was positive survival benefit. And that's not something that we've seen in any other tumour group in 1 year, and really quite dramatic differences. Now, even if you look at the median survivals with these, they were relatively small advances, but if you can select out the patients who are going to get the most benefit from each of these agents, they'll get the most durable benefits from that treatment, and that's where ongoing research needs to be. One of the real challenges that we now have as doctors in this field, 5 years ago, we really didn't have much in the way of options, and we'd try a bit of mitoxantrone, and then when that stopped working, we'd not do very much. Now that you've got so many choices, the challenge is to work out when is the best time to use each of these choices, because you want to use the right guns and the right weapons for the right stage of disease, and you don't want to use up some of the drugs that you don't need to use up until you actually do need to use them. So this is something that's also being actively researched, and some of it is a little bit anecdotal at the moment, but there's a lot of studies that are now helping guide us into which stage it's relevant to use which different agent, and there's certain factors that become important in that. PSA number, though, on its own is probably the least important of all the factors. So I know from a patient perspective, the PSA is up or down, and it's absolute and it's objective, and that's what it is, but in the pecking order of all the things that we use, it's probably one of the least important things that we use in making decisions about treatment modalities. And that's probably one of the difficulties in consultation, because the patient comes and says, well, my PSA's gone to do this, you need to do something. And sometimes it is actually better to just wait and watch, and or maybe not use chemotherapy, maybe manipulate with a different other modality. So PSA as an absolute number is not the important thing. It's what it's doing, how it's doubling, what the context of it is, where it was previously, what the symptoms that patients are getting, whether it's involving important organs or whether it's just low volume bone disease. And also we always go back to the original pathology. If it's a high Gleason score tumour, which we know is biologically more active, that will obviously also influence our decision. And then one of the other problems we have is to know how long we treat patients for, because the longer we use a particular treatment, the more toxicity you're going to get. And so we've got to weigh up when the benefits of outcome are getting less and the risks from toxicity are getting great. And those are things that are now currently being actively researched. And these are parts of the decisions that we need to make on a daily basis when we're treating our patients with this illness. So I think we can say that there have definitely been significant advances. Really, it's been quite dramatic being involved in prostate cancer research over the last 5 years, because there have been significant advances, and we've talked about 4 of the main drugs that have been instrumental in that. What we now need to do is try and work out how best to use all of these drugs and how we combine the different biologic agents with cabazitaxel, with Taxotere, and what order we use all of these drugs in. we now know that Taxotere is a standard of care. So now the challenge is to say, well, what do we do when Taxotere stops working? Whereas we never even thought about that situation in the past. Now that's become a real medical management issue. We need to look at incorporating some of these novel agents into our treatment, and it's a difficulty to actually access them because of funding issues and approval issues. And unfortunately, some of these things, for various reasons, take a lot of time for these drugs to become approved. And these guys remember very well the whole Taxotere story, 7 years ago, where it took a lot of noise from patient activity, patient groups and support groups to get the government to approve a drug which is now just assumed as part of standard of care. But these are the challenges that we have in the future as some of these new drugs become available. And then, although it is one of my biases, obviously getting people involved in clinical trials is essential. And there are a lot of reasons for getting people involved in clinical trials. Probably the first and most important should be for patient selfish reasons. People should be entering trials because they think there is a potential for personal gain. And that really would be the main reason that I would encourage people to go on trials, because hopefully what it will mean is that they're accessing a drug or an agent that they otherwise wouldn't be able to access. And I definitely don't think patients should go into it for altruistic reasons. It's a nice side effect, but that should not be the individual patient's motivation for going on to a clinical trial. There are certainly benefits in going on clinical trials because it does help us push the barriers. And, you know, the Taxotere trials were done in 2000. Now it's just standard of care. Cabazitaxel studies were done in 2009, and now it's in the next year or two will become standard of care. So we can see that those trials are actually in our lives being translated into useful treatment modalities. There's also a lot of other benefits in being in a clinical trial, because there's a lot of close monitoring and things which does make it the supervision much closer. But clinical trials are also not for everyone, and there's certain trials that are relevant for particular stages of a patient's disease. So a patient may be at a particular stage of the disease where a trial asking a question or dealing with that particular issue is not relevant. So a clinical trial should just be one part of the therapeutic modalities that we talk about, but it's not always appropriate for a patient at that time. So this is a slide that I love. In your case, Dave, there's a choice: elective surgery, outpatient medicinal care, or whatever in that box that our lovely Carol is holding. And what we're trying to do now is have a better understanding of what's in that box and what's more relevant for each patient. So just finally, I just wanted to let you know about some of the trials that we have open in the SAN at the moment. And the reason I've set it up in this way is because whenever we're looking at a particular disease state, we always need to say, well, what would we do if there was no trial available? And the first disease state that I talked about was, these are all patients who've got hormone refractory disease. And so these are patients who've got low volume, metastatic, low risk metastatic disease. So slowly growing disease where the next line of treatment, if you weren't on a trial, would be chemotherapy. But clearly those patients wouldn't need chemotherapy. So the standard of care at that stage would be to observe them. And we'd monitor them very closely, and when things changed, we'd put them on chemotherapy. So the standard of care in that situation would be observation. There is a trial that's open. Now, the trial that's open for this stage of disease is testing this drug called MDV-3100, which is a novel agent that's interrupting the androgen receptor that we saw on that slide. It works in different ways that the androgen receptor function. And this is a placebo-controlled trial. So half the patients will get placebo and half the patients will get this agent. Now, people always feel concerned about going on a placebo-controlled trial because they say, doctor, you're not giving me any treatment. But the only time placebos are able to be used is if the standard of care at that time would be a placebo. So you could never use a placebo-controlled trial when patients needed active treatment. So if someone needed active treatment, then you could, and that active treatment was going to be Taxotere, then you could have Taxotere plus another agent or Taxotere plus placebo. So always patients need to be getting on a clinical trial at least what is considered the minimum of standard of care for that level of disease. So in this sort of situation, the way to look at that is that half the patients will actually be getting an active drug that they wouldn't otherwise be getting. But these are the issues. Now, placebo-controlled trials are not always for everybody because there are some concerns with doing that, and so that would be something that you talked with your oncologist about. But it would be, I think that's a very good study, and that's a study that's open at the moment. In patients who have got metastatic disease, first-line treatment, so as you can see from the original data that we presented, if they met certain criteria that they needed systemic treatment, Taxotere would be the standard first-line treatment around the world. What we're doing at the moment is saying, well, we know that cabazitaxel worked better in the second-line setting, so what we're trying to do is say, well, let's see if we bring it in the first-line setting. So here is a randomized control trial looking at Taxotere versus 2 different doses of cabazitaxel. So you could see in this group of patients, you could never do a placebo-controlled trial because placebo would be an less than adequate standard treatment. So this is a trial comparing 3 different active chemotherapy drugs to see which is the best of those 3 agents. After patients have been on Taxotere, we talked about those patients who still had active disease after Taxotere. The standard of care would probably still be mitoxantrone, or some people say, there's not going to be a major benefit from chemotherapy, the risks are higher, potentially do observation. But most people would recommend mitoxantrone. This is a study that's now comparing cabazitaxel, which we saw was a bit better than mitoxantrone in the previous study, looking at 2 different dose levels of cabazitaxel. So patients could elect to either go into what's considered a standard of care or potentially consider going into that study where they would be getting 1 of 2 active agents. And then finally, in a group of patients who've got slowly growing, low volume, not active metastatic disease who've previously been treated with Taxotere, the standard of care for those patients would be to observe them. And so we're doing 2 studies which are comparing, one is abiraterone, which is an expanded access program, and another one which is comparing a newer drug, which is probably the next generation of abiraterone, which works a bit more specifically than abiraterone, and that's comparing placebo because the standard of care would be observation. So I hope that just clears what clinical trials are open, but more important, the concepts of clinical trials is that we have to use what is considered at least the standard of care for that level or that stage or that process of disease. So just to conclude some of the take-home messages, the fundamental message is that it's a heterogeneous disease, and people can never say, oh, I know someone who has prostate cancer, he's doing this, he's doing that. It's irrelevant. It's like talking about diabetes and hypertension. They are completely different diseases. So we need to know what the individual factors are for the individual patient before we can pass comment about how best to be treated. Individualized treatment is what it's all about now. We know that we have seen some progress, and what the challenges are now as to how we integrate all those new treatments with the targeted treatments, and that's what's hopefully going to happen over the next few years. And I can't not drop in this line once more. There were 3 positive trials in 1 year in 2010, and obviously highlighting the importance of clinical trials. And just finally, this is a slide a patient gave me a few years ago, and as much as we think the clinical trials and all of that's important, the big C obviously hasn't heard of the big me. And obviously and I had to clarify this at a talk I gave, it's not the big me, it's the big patient. That's what I mean, it's the patient who's saying that, not the doctor. So I may stop at that. And
we know what you mean, Gavin. Thank you very much, very informative. Now, I'm sure there's going to be some questions, but and there's the first one down here from another David. But before I pass the microphone to that David, Gavin, when we talk about these subjects that you've talked about tonight, how would you recommend people in this audience really learn more about clinical trials that are available, and how do they get on a clinical trial? Because that's a question that's often asked to us. So
not every centre can have every clinical trial open, but most of the main centres I think we're very fortunate in New South Wales, most of the main centres will all be involved in clinical trials and clinical research, because we really see it as an integral part of cancer care is to have access to clinical trials. And the cancer world is a relatively small world, and we all kind of know who's doing what trials. So I think the way to deal with it is that we should always be patients should always be asking the doctor, is there a relevant clinical trial that's appropriate for me at the time? And if I don't have a particular study that I know a patient would benefit from, but I know my colleague down the road or even on the other side of Sydney would benefit from, we would refer our patients to to those centres. Now, obviously, that does make it a little more challenging to participate in the study if geographically it's not as easy, but that would become a patient decision. But we would all work together, even though we're running separate centres, that if a patient needed a particular study that I had that they didn't have, I would look after them during the time that they're on that study with the input from the referring oncologist, and when that study was over, they'd go back to the referring oncologist. So there's a lot of cross-referral, and there are some resources that list all the clinical trials that are open that we can access. So if I've got a patient with prostate cancer, low volume metastases, and I'm not sure who's doing what studies, I can punch those data into the network, and then they'll say, well, look, it's being done at Westmead or whatever, and then I would refer it to one of my colleagues. So there is a lot of cross-referral. Sometimes it's a bit, people forget about it because it does seem a bit more cumbersome to say, well, we can give you the treatment here, but you can go and have it on the other side of Sydney. And sometimes it does require a bit of input from a patient to say, look, I am interested in trials, what's out there. But most of I think, as I said, we're very fortunate in certainly the metropolitan parts of Sydney and most of the big cities that we all kind of work together, and so I think we'd all know what sort of studies each of us are doing.
Now that's good. That's a good clarification. Now, David.
Yeah, I noticed you haven't talked about radiation at all.
There are two reasons for that. One, because I'm not a radiation oncologist, and I'd be talking out of my depth. But what I specifically try to say in this talk is that I'm focusing on patients with hormone refractory disease. So going back to this original slide, radiation, I didn't mention it, just so my radiation colleagues don't shout at me. Radiation would be an integral part of treatment with localized disease. But our discussions tonight were really on this part of the spectrum. So there's a whole lot of issues with radiotherapy in the localized disease forum. But there are also roles for radiotherapy in people with advanced or metastatic disease where we use it just to treat a small area that's causing pain or for symptom control. That is not so much a part of the systemic treatment that's going to have an impact on the survival or the outcome. That is more a treatment to try and help control a particular symptom. So radiotherapy is a very important part of our treatment, even in patients who've got hormone refractory or metastatic disease, but it's not what I would see as the scope of this discussion, but certainly a very important part of the treatment. And while on that topic, having the way that we treat this disease is very much a multidisciplinary approach. So we would utilize our radiotherapy colleagues. Urologists still have a very important role in playing in people who've got advanced disease, because there's still a whole lot of problems that people can have with the plumbing or that sort of thing, where we'd still get urologists involved. We also work very closely with our pain and palliative care doctors, because even though we're still actively treating people, optimizing symptom control is a very important part of the treatment. And then there's a whole lot of other allied and support teams that are part of that, the way that we treat the disease, even when it is hormone refractory. So I think you raise a good point, that it's really important to highlight that all of those people are part of that team, and I would just provide the one sort of component of that, and that's what this discussion was about. Does that answer your question?
So if one had surgery, then the PSA started rising.
Yep.
Then you had radiation.
Yep.
Then the PSA has gone to nearly zero.
Yep.
My understanding was that was the end of my story.
That is that. So if someone has surgery and then your PSA starts rising, if it's a slow, again, it depends on the biology of the disease and what the pathology showed, but there's certain features on the pathology report that tell us that if this causes a problem, it's more likely to be a localized problem. And then we also look at the way the PSA is changing. And in some situations, when the PSA comes up, it is suggestive that it's PSA coming up just because of localized disease. And then radiotherapy would be a treatment modality there, and that is still sitting in this part of the disease. where it's localized disease. Now, a significant proportion of those patients, as I said before, that would be that the disease is over, but there will be some patients where it starts coming up, and that's when we start looking at these other situations. But I don't want to comment about your disease without looking at your pathology, but it sounds to me that that's where it is.
Generally, how long would clinical trials run for? Is there a standard time, a couple of years, or?
No, it depends on what the question being asked is. So some situations the disease is very aggressive and changes very quickly, and in those situations you'd expect to get a result in a short period of time. But a short period of time in clinical trials is still in the order of years. But there are some studies which are what we call adjuvant studies, not so much an issue in prostate cancer, but in some other tumour groups that we treat, where we remove all the tumour. I mean, if we use the breast cancer example, we remove the breast cancer tumour, and we know that some patients are going to have tiny microscopic cells that we can't see. And we look at giving those patients what's called adjuvant treatment, or mop-up, or insurance treatment. Now, because we would expect that even in the people who've got micrometastases, that disease is going to take many years to come back. Those studies need to wait for those many years for the disease to come back and then to see the results of those. So adjuvant studies can take 5, 10, 15 years. Screening studies, so there was the whole controversy, and this is certainly not the forum for this PSA screening debate, so I'm sorry I mentioned it, but just using a screening study as a debate, as a discussion.
Yeah, don't single yourself out.
The screening studies, because you're waiting for 10, 20 years till you see the results. So those studies take 10, 20 years to get. So the studies depend on the nature of the disease that we're looking at the time, and they also depend on the effectiveness of the treatment, because there are some treatments which just show a dramatic improvement. So it's not going to be a minor difference, so you can see a very clear difference early. And that's one of the important things of clinical trials, is that we don't just start the trial and wait till it ends. There's a lot of monitoring that's happening along the way, and there's defined times when there's a data safety monitoring committee that has to meet. They look at all the toxicities and say, well, you know, this is a little unexpected. We're seeing a whole lot of guys whose left ears falling off, which we weren't expecting. We need to review this data. But the other thing that they're looking at is the results. And if there's a big difference between the active treatment versus the old treatment, or vice versa, they say, well, look, this is not ethical to carry on this study. This study showing a positive result, stop the study. And in fact, so if you've got an agent that's very active, you'd get that result very quickly. Now, that's actually what happened in real life with the abiraterone story, because the Data Safety Monitoring Committee had a look at the results after, I think it was 6 or 8 months, and there was really a marked difference between the two, so they stopped the study. They stopped the study and then offered everyone who was on placebo access to the drug. Now, that's a very important thing to do, because one of the endpoints of the study, and this is where people sometimes have a bit of a bit skeptical about clinical trials, but this highlights the ethics and science that's involved in it. One of the endpoints of the abiraterone study was overall survival. So what you'd expect to see is you give half the patients the drug, half the patients have abiraterone, and if abiraterone's more effective, these guys will have a longer survival. But what they did was they looked, when they were halfway through, these guys were doing a bit better, and then they opened the data and said, well, actually this is a very effective drug. It would be unethical not to give it to these guys. So their survivals actually moved over, because they would start getting better and improve in the same way. Now, what that does to the endpoint of the study is actually dilutes it a bit, because half your patients are actually getting active drug. But still, it's they're very clear guidelines that you can't, you're not going for the endpoint of the drug, you're going for what is ethically the right thing to do. So then what we do is we don't look at overall survival as the endpoint, we look at progression-free survival till people were switched over. So that sort of study actually finished 2 years before it was expected to finish, and then everyone was offered active drug.
Hi, Gavin. Thanks for your talk. You mentioned a couple of things there, bone scan and CT scan. I've also read about something called Sand Lake imaging.
Sand Lake imaging?
Dr. Myers talks about Snuffy Myers.
I'm not
familiar.
I mean, I'm familiar with Snuffy Myers, but I'm not sure what a Sand Lake
The real question I have is, I had a bone scan prior to having my prostatectomy almost 3 years ago. I'm now on my second lot of androgen deprivation therapy. I haven't had a bone scan or a CT scan since my operation. Should I be having one? And if not, why not?
I definitely won't comment as to whether you should or shouldn't be having one. That would be a discussion for you and your treating physician. But we don't there are reasons why we don't just do CTs all the time. There is a significant amount of radiation exposure that you get with that. And so we've got to be clear that the information that we gain from knowing about that CT scan is going to affect a management decision. So I don't want to talk exactly about your case, but let's say we've got a patient whose PSA is going up slowly or even fast, but is very asymptomatic and is responding to hormones. If I did a bone scan and it showed that you had bone metastases, I would say carry on with the hormones because they seem to be working, your PSA is coming down. If I were to do a bone scan and it showed there are no metastases, but your PSA is still responding, I'd say carry on with the hormones because they're working. So in that situation, a bone scan is not going to change. The reasons we do scans is because they're going to influence a management decision. But if what was happening was that the PSA was becoming refractory to whatever hormonal treatment we were using, and we were saying, okay, well now, is this guy getting to this area? Then it does help to know what a bone scan and a CT scan shows. So most patients are on hormone therapy for many years. If we did scans on them every 3 months, the amount of radiation exposure would be a real problem. And it also means that when we actually need to expose them to all the scans and things later down the track, when we're tracking the disease and it's going to change management decisions, you've given them too much radiation. So you don't just routinely do scans. We do scans that are going to influence a clinical decision. So I would say if a PSA is just grumbling, is getting better on hormone treatment, even if it is second or third line treatment, you don't care what the CT scan shows. Well, not that you don't care, but it's not going to influence your management decision. So you should just carry on with the treatment that you're on. But it's different when they're becoming hormone refractory because then your treatment decisions are a little different. So if you've got someone who's got hormone refractory disease and has got liver or lung metastases, you're going to jump in with chemotherapy faster than someone who's got hormone refractory disease and low volume bone metastases. So at that point in time, it would be relevant to do scans more frequently.
The other question is, what's the difference between bone and CT scans?
There are different modalities, different investigative modalities asking different questions. So basically what a CT scan is where you go through a CT chamber and they basically take lots of slices through you, and it's the best way of looking at your organs, your lymph nodes, your lungs, liver, those sorts of things. You can do something to the CT scanner where you do some bone windows and you can get a sense for what's happening with the bones, but it's not the best way of looking at the bones. A bone scan is where we inject you with a radioactively labeled substance that gets taken up by bone. So you get a selective uptake to bones that are hot and active, and so you get a skeleton, you get that sort of picture which shows you where there are hot spots in the bone. So it's a better way of looking at the bone. So in some diseases that we treat, we don't do bone scans because we know the likelihood of the disease affecting the bones is not relevant. So in general, if we're treating people with colon cancer, it's much more likely to affect the lungs and the liver, so we'd concentrate on CT scans. Whereas in prostate cancer and breast cancer, it's much more likely to affect the bones, so bone scans become part of the investigator. Any investigation that we do should be based on where you expect to find a problem, based on what we know about how disease behaves, or based on what the symptoms patients tell us about. And if I knew something on that bone scan or CT or whatever test you did, if I knew A or B, would I do something different? If I show A or B and I was going to do the same thing, there's no value in doing that scan.
Young lady up the back.
I would like to know what part. Now, there's a lot of talk about women having mammograms and having excessive radiation as a result of repeated mammograms. And it's been, so I've read, where they are much better off to have an MRI, which will give them a result, but also doesn't give them the danger of exposure to radiation. Now, I would like to know where MRI scans and PET scans, what part they play in checking whether you have metastases, please.
So, firstly, the breast cancer question. The issue about screening with breast cancer is evolving. Certainly, in 2011, the best way of screening at the moment is with mammogram, plus or minus ultrasound. MRIs are certainly helping, but it's an area that's now evolving where we don't know exactly how to interpret them, but in certain situations it's a very useful tool. And I think in the future it probably will become a modality that's going to be useful in breast cancer screening. But it's not for everyone, and it's certain types of breast cancers and certain ages of patients where MRIs will become a future potential screening tool. It is available in Australia. It's currently not funded because the data don't support its use just yet, but I think down the track it's probably going to become an important thing.
And what you're saying, it's not useful
I'll come back to that in prostate.
Interpretation of prostate cancer metastases.
Yeah, well, MRI is not, MRI you've got to look at a focal area. So MRI is sometimes useful for a local problem. So if you're not sure whether there's been a local recurrence in the pelvic bed, then MRI is sometimes a useful test. But as a screening tool, it's not a particularly useful test. And to scan the whole body, it's not a particularly useful test. PET scan is also not being shown to be useful in prostate cancer yet, and it probably won't. It's unlikely that it's going to be an agent, a test that's very useful in prostate cancer. But there are certain isotopes that we may be able to label the PET with that may down the track show to be useful. But that's still a research tool at the moment. So PETs and MRI don't really have a role in prostate cancer at the moment. And just also, I don't want to ignore the issue about mammograms, because it is a very important screening test to do. And some people will say, you know, ever since we've been doing mammograms, we've been finding, you know, it's caused much more cancer. Look how many more cancers we've found. It's probably not the mammograms that have caused it, it's the mammograms that have found it. Now, there is a small amount of radiation that you get with it, but overall, the benefits and the survival benefits with mammogram outweigh the risks. Everything that we do in medicine comes with risk. But what we've got to weigh up is, if we don't do that, is that risk greater? Now, there are going to be more people who run into trouble with breast cancer as a result of not having mammograms than women who run into trouble with cancer for having mammograms.
So how often are you suggesting for a patient with treatment with Zoladex, say, and their PSA is remaining, it's only early days, I have to say, but their PSA has responded appropriately, and now it's been suggested that perhaps they'll stay on it for 12 months and then see what the PSA does and wait till it rises again and then restart the Zoladex if the PSA goes up.
Yeah.
How often should that patient have their bone scan, please?
Okay, so what we're talking about there is a little different. We're talking about the disease at this sort of stage, but I think you raise an important question, and what you're talking about there is a thing called intermittent androgen deprivation. So what we did in the past was that when someone was diagnosed with microscopic metastatic disease or metastatic disease and the PSA was going up, we used to put those patients on hormones indefinitely. And that had some problems, obviously. You know, being on hormones for a long time comes with risks, general feeling of well-being, quality of life, bone health, cardiovascular health, all of those factors. And so those were the problems with being on hormones for a long period of time. One of the research things that people were interested in was saying, well, what if someone's having a very good response to treatment? Let's stop the androgen blockade and see how they go. And there were some concerns with doing that, because we thought that that may lead to worse outcomes because patients are off their hormone treatment for a period of time. Even though they felt better, there were better quality of life things, it helped their bones, it helped their cardiovascular thing, their cardiovascular issues, was it going to have a negative impact on their outcome? And that was an area that we weren't really sure of until about a year or so ago, where there were some trials done comparing people who had continuous blockage or people who were on intermittent blockage. And what it showed is, in that the people who had intermittent blockage, that it was still safe and it didn't change their outcome significantly. But intermittent androgen deprivation is not for everyone. It's only for people who've had a very good response and it stays down, and then you've got to monitor their disease closely. Now, you monitor their disease closely with the PSA, and when the PSA goes up again, then you reintroduce that treatment. Again, I don't want to make this as a general treatment for prostate cancer. It's for specific biologies of prostate cancer and specific responses, but it talks about the concept of intermittent androgen deprivation, which is an important tool now, and it's something that we're going to be seeing more and more now that the research has shown that it's safe and there may actually be potential benefits on top of just being safe. In those patients, we wouldn't routinely follow them with a bone scan, because again, if the PSA has gone up, it doesn't matter what the bone scan shows, we need to start hormones. So the bone scan is not going to influence your decision about whether you add hormones or not. So again, it comes down to the question that we talked about earlier, is that, is the scan result going to influence the decision? Because if the PSA is going up and the scan shows no metastases, I'd probably put them on hormones. When you've got it, it's not when it just goes up once. There's certain criteria that it needs to meet to go up, and that depends on the biology of the disease, and the doctor will talk to you about, you know, when it gets to this or that, we know we need to start again. So when it hits this or that, whatever number is appropriate for that patient's disease, it doesn't matter what the bone scan shows, you're going to start treatment. So I wouldn't do a bone scan then.
Thank you. Thank you.
Yeah, thank you for your talk. You mentioned a few times with the treatments, side effects being relevant for consideration. Do you care to expand on them, please?
So, you know, obviously different chemotherapy drugs have different side effects. Probably the main one to talk about would be Taxotere, which is the main treatment that we use. And the main side effects that people get with Taxotere is hair loss, and that normally happens about 2 to 4 weeks after treatment. It doesn't happen to everyone, but most people would lose their hair with it. Probably the most difficult side effect with it is the fatigue, and the fatigue is a cumulative problem. So the first few cycles is not too bad, and then as you have more and more, the fatigue lasts longer. The most serious and life-threatening problem with it is that it can drop your blood counts. And if it drops your blood counts, then you're at slightly higher risk of getting an infection. But as long as people know about that, and if they do get an infection, they come straight to hospital, we can treat them and get them over that infection. But that would probably be the most serious side effect with it. It can also cause some pins and needles in the hands and feet. It can cause some mouth ulcers, can affect your nails. It can cause a few of those side effects, but what you would do is when you're on a particular treatment with that, you'd be seeing your doctor every time before you have a cycle of treatment to see what the side effects were for the last cycle, what we can do to try and fine-tune some of the things with that. So nausea and vomiting used to be a very big problem with this treatment, but it's not that big a problem anymore. We can, you know, we've got so many good anti-nausea drugs, especially with Taxotere, that it's very unusual. We can't control that. And so your doctor will be juggling some medications to try and make the side effects as manageable as possible. And in some situations we have to say, well, very rarely people get knocked around so much by it that we say, look, it's just not worth it. Even if the PSA is responding or the disease is responding, for that individual person, the side effects don't justify the benefit. So that would be a regular assessment and discussion with patients with each cycle of treatment. It does get a bit harder with each dose that you have, and sometimes we stop, give people a break and then start again. Yeah.
Thanks, Gavin. That's great.
I put her up to it. No, I didn't.
No, I just want to thank you because we have Yvonne McMaster speak to our group each year, and we don't get a big roll-up for her night because guys, I think, just shy away about palliative care or symptom management. And it's really good to know that you've acknowledge that tonight, and for men to take it on board because they don't need to put up with their side effects, and they can get action on it.
We actually have a palliative care physician in our practice who we work very closely with, and I think one of the problems with palliative care is that people say palliative care means that I'm dying and this is terminal care. And I think the way I understand palliative care is that palliative care has two very important roles. The one is to look after terminal care of patients, and they do that very well, and they provide an excellent caring environment and service to look after that. But most patients who need palliative care don't need terminal care. The other very important benefit of palliative care is that they are experts in symptom control. The same way as we're experts, you know, in chemotherapy, or someone's an expert in radiotherapy, you can't be an expert at everything. And so we need to work as part of the team with a palliative care doctor who's going to optimize symptom control. And I think in 2011, there's no excuse really for patients to be having uncontrolled symptoms. It's exceptionally uncommon that we can't fix them. And the main reason why we can't fix them to, you know, almost completely is because of lack of referral or lack of involvement in a palliative care service or a symptom control service. So I think that is, it's not either chemotherapy or palliative care. They work together. And maybe from a marketing point of view, they need to change it to symptom control rather than palliative care, because I think it does affect people's perception. And yeah, it just, because people hear palliative care and think it's terminal care. And it is, they do terminal care, but it's one part of their job. Bulk of their job is actually not terminal care. And the bulk of benefits that patients get from it is actually not terminal care. It's the symptom management if you involve them early. And people are also concerned that, well, once my doctor's flicked me to the palliative care specialist, he's not going to be involved. And that's not, you can, you know, you've got to, I mean, it depends on the relationship, but you've got to work well with the palliative care doctor, and our palliative care doctor treats symptoms while in parallel, you know, they'll see us have chemotherapy and see her the next day for symptom management.
Yeah, I think we do need to change the term, because we've been working at this for a long time, and people balk at palliative care.
Yeah.
And Yvonne puts it so eloquently every time, and we talk about it as pain relief and all sorts of things, but people.
But it's not just pain relief; it's everything.
No, it's everything.
It's nausea and constipation, diarrhea. There are a lot of things that, and the ridiculous thing is, and I sometimes see it when my palliative care doctor gets involved with my patients, is that she just will put them on a simple, easy medicine 101 treatment that we didn't use. It's just they think differently. You know, I'm thinking about the chemotherapy and the nausea and the neutrophils and this and that and the disease and the bone scan, and she just puts them on a bit of Panadol or Caloxyl.
Well, that's right.
And, you know, and it works. You know, and so it is good to have that.
Yeah.
I mean, that's not all they do. They also do some complex things, but it's remarkable how just thinking about it differently, they can fix it.
Well, that comment about nausea struck a chord with us, didn't it? Because so many people put up with it and they don't have to.
Well, people also think that I'm on chemotherapy and I'm on treatment and I've got cancer, so I should feel sick, I should have a little bit of nausea and I should have a bit of pain. And that's just not what it is anymore.
Okay. Can I just ask Gavin the last question, and we'll let you get away because we do appreciate it. But how many of your patients in the category that we've been talking about tonight, just as an indication for us, would be on a clinical trial, roughly?
I have a bit of a... The New South Wales average number of people on trials is probably about 5%, which is very, very low, but acceptable around the world. That's what it currently is. The Cancer Institute New South Wales is trying to get patients up to about 10%, which is still very low. But there are a lot of reasons why it's low. Some of the reasons is that they're not good trials open relevant for the patient population that's out there at the moment, the geographic issues and the costs of running clinical trials. So there is that problem. I do have a bit of a bias to prostate cancer, and we've also set up our unit in such a way that we've got almost every one of those lines of prostate cancer a trial that's open. So, you know, we've got a trial open for low volume disease without METs, one with METs, one with second line, you know, so all the different categories. So it's probably a bit unusual, but I'd have probably 40 or 50% of my patients on a trial.
That's very good.
Probably 40%, I think.
Yeah.
But only in prostate cancer. In other diseases
we're just
where
talking about prostate
we're a bit thin on trials that are open, it's much harder. But it's become a bit of a bias, so that's what's happened.
That's very good. Thank you very much. Could you help me thank Gavin for another wonderful presentation?
Thank you.